medical. Okay.
Sorry.
We'll have a more professional aspects, and then later a more patient-oriented aspect. I'll talk a bit about the different diagnostic system, different criteria for FASD, and how does this match with the official diagnostic codes that we use for FASD in the hospitals. I will talk about symptom diagnosis versus implying etiology, and how certain can we be when we say that a child may have FASD. And I will end by saying a bit about advantages and disadvantages with the diagnosis, and then we will hear Marta's story. So as you probably know, there are several diagnostic systems existing for FASD, and several countries has developed their own diagnostic system, mainly with the same key criteria, which for the most system consist of growth deficiency, typical facial characteristics, structure or functional deficits in the central nervous system, and whether the child has been exposed to alcohol in fetal life. For some of these criteria, there's quite a consistency between systems, but still, despite overlapping diagnostic criteria, there are only fair to moderate agreement between these systems with regard to diagnostic outcomes. And actually, in a study here from 2016, evaluating 5 different diagnostic systems, the proportion of participants who received an FASD-related diagnosis ranged from 5% to 60%. So you could, in one system, end up with a full FAS diagnosis, while in another system, the same patients wouldn't be into the FASD spectrum at all. So this is a huge problem for us diagnosing these conditions, because there's no gold standard. Most of the systems have several subgroups of FASD, like FAS, partial FAS, and alcohol-related neurodevelopmental disorder, and the 4-digit code also use the words static encephalopathy and neurobehavioral disorder. And these have different criteria. And as I mentioned, in the hospitals, we use the ICD-10 diagnostic system, and there is only one code, and that's for the diagnosis of FAS. There's none for the other subgroup of FASD, and I'll come back to that. For the DSM system, which is mainly used, at least in Norway, in the psychiatric departments, there are 2 codes for the diagnosis of full FAS and FASD, and I'll come back to that. Just shortly mention one of the diagnostic system, the one we use in Norway, the 4-digit diagnostic code, developed in Seattle by Susan Astley. And the 4-digit code is based on the graded presence of 4 key criteria. It's growth, its face, its CNS pathology, and whether or not there has been alcohol exposure. And then you grade these 4 key criteria from 1 to 4. And the higher number, the more severe form of FASD. And the picture here shows some of the facial characteristics for those with a full fetal alcohol syndrome. But remember, most of the children with FASD, they don't have these full facial characteristics. So by using this system, it says something about the clinical picture is fitting with FASD, but it doesn't say anything about causality. I will come back to that, because that's what's some of the problems that we face as professional diagnosing these children. So for this 4-digit code, you have the FAS, the fetal alcohol syndrome, which is the only subgroup that you can diagnose without knowing about alcohol exposure. And then you have 3 other subgroups. And for these, you have to have confirmed alcohol exposure. But remember that these subgroups, they are specific for this 4-digit code system. In many of the other systems, this mildest form, the neurobehavioral disorder form, doesn't exist. So that's one of the discrepancies between this diagnostic system. In the 4-digit code, there are quite strict criteria, facial criteria, to call it FAS, while in the other systems, these facial criteria are more relaxed, and also the growth criteria are more relaxed. So for many of the other diagnostic systems, you will have a larger proportion of patients with a full FAS than in this 4-digit code system. So these are the differences. And when Susan Astley looked at her population of FASD children in a clinic, you see that only 10% had this form, this subgroup, full FAS or partial FAS. And most of them, 44%, they had the mildest form, which is not included in many of the other diagnostic systems. So this may make a huge difference whether the child gets an FASD diagnosis or not. It's due to which diagnostic system you use. So what about the diagnostic codes that are used in the hospital that we have to label when we have assessed this child, and we have to put a clinical diagnosis on them? So is FASD really a clinical diagnosis? Well, I'll answer that question in a while. For this one system, the DSM system, it says the Diagnostic and Statistical Manual, developed by the American Psychiatric Association. They have actually a diagnosis for FASD called neurobehavioral disorder associated with prenatal alcohol exposure. And this diagnosis, you will get that if you have clinical problem in 3 areas: thinking and memory, behavior problems, and trouble with day-to-day living. But it also says that the mother of the child must have consumed more than a minimal level of alcohol before the child's birth. So here you have a criteria who says something about the amount of alcohol exposed. And we know for sure that it's very difficult to get valid information about that, especially in retrospect. For the other system, the ICD-10 system, that's the one we use in our hospital. It's actually only a diagnosis for the full FAS. And to describe the other subgroups, we don't have a diagnostic code, so there we have to use symptom diagnosis. And that's why many of these children have different symptom diagnosis. And there are advantages with symptom diagnosis. And I've written here, the more the better. And that's just to describe the complexity of the clinical picture. If you give the child a lot of these symptoms diagnosis, at least you will show that this clinical picture is complex and that you have to deal with several problems that probably will need different solutions and different treatment. So in this sense, FASD means a cluster of symptoms. And here I have chosen some of the most common ones. Many of these children have learning disorders. They have deficits in attention and executive function. They have social deficits, low adaptive functioning, visuomotor, fine motor problems, and behavioral problems. And if you have this complexity in a child, then you really should think about, could this be due to FASD? Or could you put all these symptoms together as FASD? But in hospital, there is no clinical diagnosis for this. So in the ICD-10 system, we therefore often have a lot of symptom diagnosis that we can use to describe the different clinical findings and different problems that these children have. And here you see some of those codes that has been used and has been commonly used for FASD patient care. And I don't go through them, but there's a lot of them. And you will say that some of them reflect the learning disorders, some of them reflect psychomotor deficits, some of them reflects attention and concentration deficits. So that's the alternative to have a clinical diagnosis of FASD. So what is FASD? This is from the CDC webpage showing that FASD, it says FASDs refer to a range of effects that can happen to a person whose mother drank alcohol during pregnancy. So it's quite diffuse, I think. It could happen, but on the next page it says FASD are caused by a woman's drinking alcohol during pregnancy. And that's some of the problem, because it's very seldom one cause for the child's clinical picture. The developing brain is influenced by a lot of risk factors, both prenatally, in the neonatal period, and postnatally. So even Susan Astley, who has developed the diagnostic system for FASD, she states, it is important to clarify that when we report that there is extensive evidence to support inclusion of neurobehavioral disorder, that was the mildest subgroup of FASD in her diagnostic system. We are not stating that all individuals who meet the criteria for this subgroup really have FASD. And she also continued to say, by definition, all individuals with fetal alcohol spectrum disorder have a disorder caused at least in part by their prenatal alcohol exposure. But not all individuals with this neurobehavioral disorder necessarily have an FASD. And that is very confusing for me, because she includes this subgroup under the FASD umbrella in the 4-digit code, but still etiology is very uncertain. And for foster parents and adoptive parents, it is most often useful that the child gets its diagnosis of FASD, even though we cannot know for certain that alcohol is the true etiology of the child's clinical picture. But for us working also with biological parents, it's really difficult to use this concept FASD if the etiology is so uncertain, because you actually blame the mother for having caused this condition. So therefore, it could actually be discussed that the adverse clinical consequences of prenatal alcohol exposure should still be regarded as a collection of symptom diagnosis, since the etiology is nearly always multiplex. But on the other hand, an umbrella diagnosis of FASD have a great beneficial value for the patient. And I'll come back to that. And also Martha will tell you why is it an advantage to get this FASD diagnosis, even though it's not a clinical medical diagnosis. And part of the reason for that is that umbrella diagnosis may give access to specialized treatment, services, and follow-up, while the individual symptom diagnosis may not. And especially not if you haven't got the full complexity picture. If you have only picked out one or two of the symptoms and try to treat that alone and don't see the whole clinical picture, the treatment and the services to the child will be insufficient. So if prenatal alcohol exposure is regarded only as a possible cause of the patient's clinical picture, as is the case in some of these subgroups, both in the 4-digit code system, but also in other diagnostic system. It could surely increase stigma to use an umbrella term like FASD as a clinical diagnosis, since it may inappropriately imply a confirmed causal link between exposure and outcome in that individual, which may not be true. And we have experienced that this will have legal consequences, especially for birth parents, if you put an FASD label on the child and the causal link is so uncertain that it is in many cases. Even Susan Astley says that if you have full and partial FAS, alcohol is the probable cause. But if you have the other subgroup, alcohol is a possible cause. We can't say it more strongly than that. If we do that, we will be killed by the lawyers in court. And we have experience with that. And if you look at, for instance, cancer, you do not call it cancer if cancer is only a probable cause or a possible cause of the symptoms that the patient has. We have to get it verified, but that's not possible for fetal alcohol exposure in most cases. So, should we give an etiological diagnosis like FASD to a child if alcohol is only a possible cause? No, we shouldn't. And I think that FASD is not and should not be labeled a clinical diagnosis, but should be used as a description of a clinical picture, a symptom complex associated with prenatal alcohol exposure. And that's because etiology is most often multifactorial. Here is a slide from Susan Astley. These are the risk factors among her 2,550 FASD patients. They were all exposed to prenatal alcohol, but look at all the other risk factors that we know interfere with normal brain development in a child. Many were exposed to prenatal tobacco, to other drugs. There was perinatal difficulties. Many had foster and adoptive care. A lot of them had been physically abused or sexually abused, and most of them had experienced some degree of neglect. And we know that all of these causes also interfere with normal brain development. So why should we use the FASD concept then? By using it as a concept to describe a symptom complexity, we also say that here it's no quick solution. There's no growing out of this problem, and there's no time to just wait and see, because this problem in most cases will persist into adulthood and also into into adulthood. And it must be regarded as a lifelong disability where long-term follow-up and care is needed. And if we use FASD, if we think that the child's clinical picture fits with what we know is common for children with FASD, we have quite extensive evidence-based knowledge, both about prognosis, which indicates long-term follow-up. We know a bit about intervention, what does work for these children, what doesn't work, what kind of treatment may help, what kind of services are needed in childhood, in adolescence, and in adulthood, and how can we optimize the outcome. And it's also a point that identification of FASD can be a potent motivator for mothers to abstain from alcohol in subsequent pregnancy, because we know that siblings of a child with FASD are in risk of having FASD themselves. So here I just wanted to show you this. I'm just going to finish in a few slides now. But I think this says a lot about the complexity in a child with FASD. This is actually an adolescent with age 18 years. He has normal expressive language skills like a 20-year-old. You can actually be fooled. You think he's clever than he is. But his language comprehension is only 6 years. His time and money concept, 8 years. Emotional maturity, 6 years. Physical maturity is normal. Reading skills, quite good. Social skills, terrible, like a 7-year-old. And daily life skills, like an 11-year-old. If you catch this clinical picture, you see all this fragment of the symptom complex. You will get a much better understanding of the child and the child's needs. And early detection of FASD is important because with the development of better and more targeted educational social support programs, there is an urgent need to make the appropriate diagnosis at the earliest opportunity. And this makes significant differences to the developmental progress of the child. And it also helps parents and those working with the child to cope more appropriately with the child's difficulties. And you have to have a lifelong perspective. And early diagnosis allows parents to best accommodate the child's environment to meet all their needs. And if you don't do that, if these children are not diagnosed early, then the secondary difficulties appear with poor educational attainment, mental health problems, and a higher risk of becoming addicted to alcohol. So my last slide before Marta takes over. I think we should use, even though we can't call it a clinical diagnosis and put a diagnostic code on these children when we assess them in the specialist services, we should still use the FASD concept because, as I've already mentioned, there are clear benefits of using the FASD concept. We have programs, parental psychoeducation programs, based on the diagnosis of FASD that we know can work. There are tools and treatment based on this diagnosis. The complexity may be visualized. We can diagnose comorbidities like ADHD, for instance, or autism spectrum disorder, or Tourette syndrome, as we often see. And we know from experience, our own experience, that the staff in the education sector will be more supportive if aware of brain damage in a child. There are certainly, or could be certainly, some disadvantages, and I've mentioned the stigma of blaming the birth mother without knowing exactly whether the alcohol is the cause. We have chosen now to call it a risk factor together with other risk factors. And it may perhaps be a stigma for the patient, I don't know. So that was what I'm going to say. I'm hoping I haven't confused you all, because I think it's difficult myself to differ between this diagnosis system and how we can label them in hospital. But of course, the most important is to evaluate these children multidisciplinary and get an overview of their strengths and weaknesses and make services and treatment plans according to that. So Marta,